Hello, Memory Gosa, and I'm happy to be here with you today talking about thickening practices for infant populations. I am an associate professor and chair of the Department of Communicative Disorders at the University of Alabama, and that's who I receive salary from. I do PRN work for Druid City Hospital and Le Bonheur Children's Hospital. I receive royalties from TEMA for a textbook that I co-edited with Dr. Deborah Suter. And I also received honorarium from Dr. Brown's Medical, which is part of Dr. Brown's company, for this presentation. I'm also an elected member of the CAA and editorial board member for AJSLP, co-founder of the Alabama Dysphagia Collective with Dr. Kendria Garand, and then I'm a member of ASHA, the Dysphagia Research Society, and the Voice Foundation. So today we're going to talk through several things related to thickening practices with infants, and you can check the learning objectives in your handout. So we want to start by discussing the benefits of thickened liquids because there are documented benefits to using thickened liquids across the lifespan. And today we're really going to focus in on those benefits within the pediatric population, specifically for infants. So thickened liquids are a common intervention treatment for both gastroesophageal reflux disease and for pediatric dysphagia. It's generally a low risk, non-pharmacological intervention that can be applied when children have dysphagia that results in airway compromise or gastroesophageal reflux disease. And we have a fair amount of empirical evidence that really establishes the efficacy of this intervention. So for gastroesophageal reflux disease, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, NASPGHAN, and the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition, ASPGHAN, recommend thickening as a first-line approach for gastroesophageal reflux disease in infants and young children. And for reflux, thickening the breast milk or the formula works by moving feeds to the antrum and away from the lower esophageal sphincter, which helps to reduce the number of reflux events. It also reduces the amount of reflux that might advance to the oropharynx if it does escape from the lower esophageal sphincter. In contrast, for pediatric dysphagia, thickening is really the last option that will be thought about and recommended if it's shown to be efficacious. So it's the last option to compensate for oropharyngeal dysphagia that results in airway compromise in infants and young children. And it works by first slowing the rate of liquid flow through the upper aerodigestive tract, and it also increases the cohesiveness of the bolus, both of which, slowing the flow and increasing the cohesiveness, contribute to reduced airway compromise events during the swallow. So when we think about the benefits of thickened liquid for infants and children when they have gastroesophageal reflux disease, we have a number of different options for providing a thickened liquid. First, we'll talk about hand thickening the formula, where you would add a commercially available thickening agent or a rice cereal or an oatmeal cereal to expressed human milk or to formula and mix it by hand. When this has been looked at in the empirical literature, it's been shown to decrease emesis and regurgitation episodes. It also helps to reduce the volume or the amount of emesis that happens, and it reduces the time spent crying. We see increased sleep time after feedings when we're using a hand thickened formula, and it's also been shown to reduce the maximal height of refluxed material within the esophagus. Further, it's never been shown to have an adverse event within the empirical literature. If you're using an anti-regurgitation formula, something like an Enfamil AR, we see similar efficacy as hand-thickened formula. Using an AR formula tends to be more convenient. It offers a standardized viscosity that doesn't significantly change over time. The drawback to using an AR type formula is that there's increased expense as compared to using a hand-thickened formula with oatmeal cereal or a rice cereal as an example for thickening. We can also use blenderized formulas when we're talking about doing thickening for tube feedings for reducing Symptoms of gastroesophageal reflux disease, again, we see similar efficacy as using a hand thickened formula. The NG tube requires the use of specialty formulas that are thin enough to not clog the NG tube, so something like an Enfamil AR. And what we see when we're using blenderized formulas for thickening tube feedings is that there is a reduction in the amount and number of regurgitation and choking, gagging, and coughing symptoms that we see, and a decrease in the number of sleep disturbances that occur because of reflux events. Now, if we flip and we think about the benefits of using a thickened liquid for pediatric dysphagia, we know that it's best practice to implement thickened liquids following instrumental assessment, where we've evaluated all the options for reducing the number of penetration, aspiration, or nasopharyngeal backflow events, or eliminating them altogether. So typically we'd start with positional change or modifying the flow rate with a slower bottle nipple system that helps to reduce the speed with which the formula or the expressed human milk is extracted. And if neither of those two things would work, and we would also try things like external pacing. If none of those other things work, then we would think about texture modification with thickening to try to eliminate or reduce the number of penetration and aspiration events. So that instrumental assessment allows for the determination of which liquid consistency or position and method of delivery improves swallowing function and reduces those airway compromise events or eliminates them altogether, ideally. The focus of management is both to ensure safe and efficient oral intake for the promotion of adequate nutrition and hydration in the infant. And there's been some recent studies that one I want to highlight here from Dr. Claire Miller and her associates there at Cincinnati Children's, where they've looked at the predictive value of laryngeal penetration events. From the adult population, we hear more discussion and maybe some controversy around intervening with texture modification if the person that's being evaluated just has episodes of laryngeal penetration without aspiration. And we know that infants are not just little adults, that they have unique characteristics both in swallow function and in developing body systems, including their lungs. So Dr. Miller's group put together this study where they were looking to determine the predictive factors for aspiration in a cohort of pediatric patients that had video fluoroscopic swallow study. The goal was to characterize the relationship between aspiration and penetration according to the depth of penetration, and they used the penetration aspiration scale, the frequency of penetration, and the liquid viscosity. Finally, they wanted to determine which penetration events were less likely to be associated with aspiration. So the goal was to determine what, if any, predictive value episodes of laryngeal penetration, like we see documented here, what relationship those had to eventual aspiration in infant populations. So they did a retrospective cross-sectional analysis of a random sample of 97 patients who had undergone video fluoroscopic swallow study at their facility. They used the presence or absence of aspiration and the response to aspiration as defined by the penetration aspiration scale for their outcome measures. And the participant characteristics are highlighted here. So it was a median age of 24 months. The majority of the patients that they included in this study were male. The primary diagnoses included neurologic, cardiopulmonary, and anatomical or structural anomalies. And the majority of them had additional comorbidities in their sample. So in addition to the primary diagnosis, there were other secondary diagnoses that resulted in the individuals being referred for video fluoroscopic swallow study because of concern for dysphagia. So looking at their data, they pulled all of the information into a multivariate regression analysis. And when they did that, the frequency of penetration of thin liquids was a significant predictor of aspiration of thin or thickened liquids. So they used the penetration aspiration scale, and then they looked at frequency and put it into one of four categories. One would be there was no penetration or aspiration observed. Two would be infrequent or occasional penetration events. So at least one event to less than 30% of the total number of swallows observed had penetration or aspiration. Three was intermittent episodes of penetration, so 30 to 40% of the total swallows, and then frequent episodes of penetration, which were then 50% or greater of the total swallows observed, is how they coded the frequency of penetration for thin liquids here. And what they found then was that it was only the frequency of penetration that was a significant predictor of aspiration of thin or thickened liquids during the study. So age, gender, depth of penetration, the primary visit diagnosis, whether it was neurologic or anatomic or cardiopulmonary, and any of the patient's comorbidities did not independently predict increased frequency of aspiration. It was the frequency of the penetration events that then was the significant predictor of aspiration of thin or thickened liquids. It's really important because it gives clinicians the information then to act in accordance with safety and protection of the developing pulmonary system there, that if we're seeing frequent 50% or more episodes of penetration during swallows of thin liquid, we know that that's a significant predictor of eventual aspiration of both thin and thickened liquids, according to this study here. So their conclusions were that the frequency of penetration and sometimes the depth of penetration on video fluoroscopic studies are separate risk factors for aspiration. And frequency, remember from the previous slide, was a significant predictor for aspiration of thin and thick. Both increased frequency and depth of penetration are associated with increased episodes of aspiration, but shallow intermittent laryngeal penetration is not consistent with clinical aspiration. So it gives us information to help inform our practice during video fluoroscopic studies. If we are seeing 50% or greater numbers of penetration during swallows of thin or thicker liquids, then we know that that's an independent risk factor for aspiration, and we should intervene with trying different strategies to help reduce that number, things like changing in position, changing bottle nipple systems to reduce the speed of liquid flow. If those things don't work, we've tried pacing, we've tried all those other things, and of course, intervening with thickened liquid or a texture modification would be appropriate in those cases then. From other empirical study, we know that infants with silent aspiration had reduction in hospitalization for acute respiratory infection when a thickened liquid was introduced into their diet. In infants and children that had isolated laryngeal penetration, providing thickening was more effective than other feeding interventions in decreasing the symptoms and respiratory hospitalizations that occurred. For infants and children that have laryngomalacia, that can be effectively managed with thickened liquids. We also see infants with acute bronchiolitis benefit from thickened liquids during that acute illness. Infants with bruits or brief resolved unexplained events had reduction in persistent aspiration-related symptoms when thickened liquids were introduced. And thickened liquids will reduce the need for G-tube placement in some populations as well. Also, we saw in additional studies that in comparison to children with aspiration that are fed via G-tube, children that receive thickened oral feeds had decreased hospitalization risk as compared to those that did not receive the thickened oral feeds. So all of this points us towards the benefits of using thickened liquids for dysphagia management in infant and pediatric populations. In some recent studies here, we see infants and children that have dysphagia that received enteral feeds that were thickened through tube. That reduced the risk of reflux-related aspiration events. We also see from the work from Cheryl Hirsch and her colleagues where they reported that addition of free water to blenderized feeds actually decreases the thickness, and it increased the pulmonary risk for those infants that were receiving tube feedings that had been thinned with free water. Infants with NG tube feedings can receive benefit of thickened feeds when we use specialty formulas like Enfamil AR, so Enfamil added rice, also sometimes referred to as Enfamil anti-regurgitation. Those AR formulas administered via NG tube, we see improved pulmonary outcomes when we provide thickened liquids through the tube feeding that way, because it reduces aspiration risk from refluxed material as well. So hopefully that helps to set the stage about why we would use thickened liquids. Everyone who works in this population understands and recognizes that it is not a simple thing to do, that it requires a lot of planning and time and resources from the speech pathologist or the occupational therapist or the dietitian, whoever is managing the implementation of the thickened liquid protocol is going to invest a fair amount of time in doing that and training the family and helping the family become confident in their application of that thickened liquid recommendation. But there's good data, there's good empirical data to support us doing that in terms of feeding and swallowing outcomes for infants and young children. So let's switch gears just a little bit and think about what our options are for providing a thickened liquid for infants and young children. We know that thickening is complicated. So the thickness of the formula or the expressed human milk that we're trying to create at a NC level 1 or 2 or 3, the resulting thickness is influenced by a lot of different variables. The type of thickening agent that we use, whether it's a gum-based agent or a starch-based agent or a cereal, all of that is going to influence the resulting thickness. What type of liquid we're mixing it with, so whether we're mixing it with expressed human milk or whether we're mixing it with a formula, what caloric density the formula is prepared at, all of those things are going to impact the resulting thickness. We know that a lot of the thickening agents that are commercially available on the market were originally designed and implemented for managing dysphagia in adult populations. Adults drink liquids that typically are not calorically dense, water, juice, coffee, those kinds of things. While they might have carbohydrate source from sugar, they don't typically have a lot of protein or a lot of fat in them. And the more calorically dense the liquid is, the more it interacts with the thickening agent, and the variation then on thickness is impacted by that base formula and the makeup, the nutritional makeup of that liquid itself. How much we're mixing the base formula or the base fluid, how much of that we're mixing with the thickening agent makes a difference in how thick the resulting liquid becomes, what temperature it's at. Again, adults tend to drink things at room temperature or sometimes chilled and over ice. That's different to infants who are more likely to drink something at a room temperature or heated, to approximately body temperature. And certainly breast milk is served at that body temperature there. Standing time, so how long between when we mix something for the infant to consume, and then the time that elapses from mixing to when we actually are able to give the infant that breast milk or formula there, that can influence the resulting thickness, even down to how we mix it. If we use a fork to mix it up, or if we shake it in the bottle, or if we use something like an immersion blender to prepare the thickened liquid, all of that will have an impact on the resulting thickness of the liquid that we've prepared. And that is why thickening is so complicated in this population, and why so much time and energy has been spent looking at how do we create the desired thickness with the resources that we have available to us. So thinking about that, if we're thinking about using commercially available thickening agents, the thickening agent that we use needs to be for children, and it should be labeled as suitable for use with infants and children with dysphagia. The packaging should contain really clear instructions on how much thickening agent is required to prepare the fluid that's consistent with the level set out by IDSE that we've confirmed is effective with instrumental assessment. Speech pathology staff or dietetics, pharmacy, and all the medical staff that are involved with the infant's care should be vocal or should have a say in deciding which type of thickening agent is suitable for the infant that we're working with. And then we also have to be aware that some thickening agents are going to contain allergens, and we should take particular care if there is a suspected allergy or intolerance to corn, wheat, or gluten with the infant that we're working with. So most suppliers currently of thickening agents don't recommend the use of their products with infants prior to term age. So if we're working in the neonatal intensive care unit and we're working with infants that have not yet reached term age, have not yet reached their due date, then most commercially available thickening agents they do not use in that population until the infants are term age. Also, if the child has certain types of gut pathology, the recommendation is not to use commercially available thickening agents because some kinds of thickening agents may not be readily digestible by the premature or pathologic gut and can possibly cause further gut complications. Along that same line, many suppliers of xanthan gum-based products don't recommend the use of their thickening agent with children under 3 years of age. So this would be products like Thicken Up Clear or Simply Thick that use xanthan gum as the thickening agent, the primary thickening agent in those products. So what we have available to us right now, some options there are using an anti-regurgitation formula right now. Enfamil AR, I believe, is the option that's currently available. We can also increase the caloric density of AR formulas if we're trying to create a consistency that is thicker than the baseline consistency. We can use infant cereal like rice cereal or oatmeal cereal. There are some commercially available thickening agents that are labeled and say they're appropriate for use in pediatric populations. And then there's some work that's come out in the last 2 to 3 years that talk about using food-based products. So using yogurts and baby foods to thicken expressed human milk or to thicken formula that may be an option for some of our older infant population. So let's think through both of those. We can use an AR formula, an anti-regurgitation or an added rice formula to provide a thicker liquid there. In this study that was led by Caitlin McGrattan, Dr. McGrattan and her colleagues, they looked at 2 anti-reflux formulas that were available on the market at the time, and they tested them at 20 calories an ounce in both their ready-to-feed formulation, so already mixed with water. All you have to do is open the package and serve the infant there. And then we also looked at it in graduated caloric densities in the powder formulation. So from a tin with the powdered formula, and we add the water to it, and we just increased the density of the formula, the caloric density of the formula, to look and see how that impacted on the overall thickness. And the goals were to determine the effect of those clinical variables on the thickness of Enfamil AR and Similac Spit Up in both the ready to feed and the powder formulations to see what all the options were for that. So the first thing that they looked at was time. So in the ready-to-feed formulation, so already constituted, mixed with water, ready to go as soon as you open the package, Enfamil AR ready-to-feed was slightly thick at baseline. So an IDSE level 1 right out of the package there. Similac Spit Up was a thin consistency or IDSE level 0, and those remained constant. Those levels remained constant for both Enfamil AR and for Similac Spit Up throughout the 30-minute testing period. So then we looked at the powder formulations. Enfamil AR started out as thin when we mixed the powder with water, but we saw a steady increase over 30 minutes that resulted in it reaching that slightly thick or IDSI level 1 consistency by 20 minutes. With the Similac spit up, it remained a thin liquid consistency throughout the 30-minute testing period. Next, we were thinking about caloric density and how that impacted the resulting thickness. So with the powder formulation, for Enfamil AR, there were stepwise increases in thickness with every 2 kcal per ounce increase of caloric density beyond 22 calories per ounce. So 20 calories an ounce, 22 calories per ounce, were at that slightly thick IDSI level 1 consistency after 20 minutes. And then we saw increases in thickness with every 2 calories per ounce that the formula was increased after that. All formulations of Enfamil AR powder formula increased in thickness throughout that 30-minute testing period. Similac spit up did not exhibit any change in thickness based on caloric density, and it remained at an IDSI level 0 or thin liquid consistency throughout the testing period. So here you can see the Enfamil AR at 20. This is the powder formulation, so powder then mixed with water. Starting thickness and then after 30 minutes. So the 20 and 22 kcal per ounce started as soon as we mixed it up and measured it. It was at a thin liquid consistency, but by the end of 30 minutes, they had both reached that slightly thick IDSI level 1 consistency. At 24 and 26 calories an ounce, immediately after mixing, they were at a slightly thick consistency. And after 30 minutes, they had reached a mildly thick consistency. So there was a gain of 1 IDSI level from slightly thick to mildly thick over that 30-minute testing period. With 28 calories an ounce and 30 calories an ounce. For 28 calories an ounce, it started at slightly thick, but then we saw it jump to a moderately thick consistency. So it increased in thickness by 2 clinical thickness levels here. It went from slightly thick up to moderately thick after 30 minutes. And Enfamil AR powder formulation mixed to 30 calories an ounce started at a mildly thick consistency, or what we used to call nectar thick consistency, and we saw it increase up to that moderately thick consistency after 30 minutes. That's important to remember or to think about, because on when you think about the infant feeding time, it is usually anywhere from 20 to 30 minutes. So we have to be aware that the powder formulation of Enfamil AR is changing thickness consistencies during that 30-minute time frame, at least when it's sitting in a bottle, not being agitated, not when the infant's not actively drinking it. We're thinking about it in the lab. When it's sitting over that 30-minute time frame, we do see it increase in thickness. Next, we considered refrigeration and the impact of refrigeration on the caloric density and the thickness of those AR formulas. So refrigerated storage, both formulas showed non-significant trends of increased thickness when we tested them cold. And we saw thinning after they were reheated to baseline refrigeration values 30 minutes after mixing. And we can see a quick chart here with that Enfamil AR. This refrigerated time point here. You can see the slight changes in thickness with refrigeration that were noted there. Another option to consider for thickening is using infant cereals. So the FDA continues to recommend that we use oatmeal cereal, not FDA, the American Academy of Pediatrics recommends that we use an oatmeal cereal due to the perceived potential risk with using significant amounts of rice cereal in the infant diet. So, in response to concerns over arsenic in rice cereal, the American Academy of Pediatrics has recommended that parents of children with gastroesophageal reflux disease or dysphagia that have thickening as a recommendation use oatmeal cereal instead of rice cereal to accomplish that thicker consistency. The rationale is that children with GERD or with dysphagia are exposed to more rice cereal and therefore more arsenic for longer periods of time. We do know that infants with increased exposure that would be coming at a time of really rapid development, and it may be the infants may be at the greatest risk for side effects of arsenic during that time, and that's why the American Academy of Pediatrics propose oatmeal as a safer alternative there. The American Academy of Pediatrics also recommends following consumer reports suggested intake of 3/4 a cup of infant cereal per day, if you're using rice cereal there. So 3/4 a cup is equivalent to 36 teaspoons of rice cereal per day, which does add an additional 180 calories per day. So we have to have discussions with patients and families that focus on balancing potential risks with the clear risks of untreated oropharyngeal dysphagia and reflux there. Also, the amount of rice cereal or oatmeal cereal that's recommended to achieve different IDSI levels varies by empirical study and by clinical location, where I've done informal surveys about how much are you using to create different consistencies. And so what I did here was pull together some of the reports from the literature on using rice cereal to give you an idea of how much rice cereal would be necessary to create the different IDSI levels. So looking at this first study from 2017, we used a Gerber rice cereal, and we were mixing 1 teaspoon of rice cereal to 1 ounce of just a standard 20 calorie an ounce formula. And you can see the different levels that were created there. 5 minutes after mixing and then 30 minutes after mixing. And the goal was to create, with the 1 teaspoon of rice cereal, the nectar consistency, or what we now refer to as an IDSI level 2, which it was successful 5 minutes after mixing. But then as it sat, again, unagitated, it just sat in the container, and then we remeasured it after 30 minutes. We saw that it had dropped a level and was not as thick as it started. And that's because rice cereal and oatmeal cereal too tend to fall out of the mixture if they're not being agitated. So we see then the cereal kind of fall to the bottom of the mixture and the liquid sit on top, where you have kind of a thin liquid on top and more of a sludgy consistency on the bottom. And that's what we saw there. When we were trying to create an IDSI level 3 consistency using rice cereal, we used 1 tablespoon of rice cereal to 1 ounce of the standard Good Start formula. And we see that effect of it kind of falling out of suspension, with the rice cereal falling to the bottom after 30 minutes, with the thin liquid sitting more there on top. In this study from 2021, we were using a beechnut rice cereal, and we used 2 tablespoons of the rice cereal for 4 ounces with different formulas. 5 minutes after mixing, that created an IDSI level 1, or what we used to call a half nectar consistency, with the exception of Similac Advance, which did not reach the desired thickness level with the 2 tablespoons there. We then used 4 tablespoons of this rice cereal for 4 ounces with different formulas to attempt to achieve an IDSI level 3, or what we used to call a honey consistency, and that was successful across all the different formulas that we tested there. Looking at the options for oatmeal cereal, this study from Brooks and colleagues from 2024 used 1.5 teaspoons of oatmeal to 1 ounce of expressed human milk. And you can see that they tested it at different time points and at different temperatures. And what they found was that it mixed anywhere from from an IDSI level 2, or what we used to call nectar consistency, immediately after mixing. And then 5 to 20 minutes after mixing, it also appeared to thin down to an IDSI level 1 or a half nectar consistency. And we see that across different time points and degree temperatures there as well. Looking at this study from 2021, we used 1 3/4 teaspoon of oatmeal with 1 ounce of various formulas. Immediately after mixing, that produced the desired IDSI level 2 or nectar consistency for 67% of the formulas that we were testing. And then it produced IDSI level 1 or a half nectar consistency for the other 33%, or the other 3 formulas that were tested with that recipe. Looking at trying to create a level 3, or what we used to call honey consistency, 2.5 teaspoons of oatmeal cereal for every ounce of formula did consistently create that IDSI level 3 consistency immediately after mixing. So all of that just to point out that there are different reports, and oftentimes you will have to test at bedside or within your facility to establish what range of cereal that you'll need to add to the different formulas that you have available in your hospital. And then they'll have to be retested and confirmed over time as things change within the formulas, as different ingredients are added, or there's different changes to the makeup of the macro and micronutrients in the formula there. What we know consistently from the literature is that infant cereals, whether we're talking about oatmeal or we're talking about a rice cereal, they can separate into thin fluid and then that kind of solid mass at the bottom. We know that sometimes the grains can block the nipple and make it difficult for the infant to extract. They might contain potential allergens, so you have to really read the instruction or the ingredient list on the package there. There is clinical reports of increased risk for constipation, and then we know that it significantly increases the energy content of the feeding, so it does increase the amount of calories that the infant is getting with each feeding there. As an example of that, a teaspoon of rice cereal or oatmeal contains 5 calories an ounce. So if you add a teaspoon to 1 ounce of formula and you're using just a regular 20 calorie an ounce formula, then that takes it to 25 calories an ounce, which is a 25% increase in the number of calories. But if you're using a tablespoon of rice cereal, that then is 15 calories an ounce, which takes a 1 ounce serving of formula from 20 calories an ounce up to 35 calories an ounce, which then is a 75% increase in the amount of calories that the infant is getting with each ounce of formula. So really important to consider and work with our dietitians there. There is one commercially available option for thickening right now. That's the gel mix. So gel mix can be used with infants that are at least 42 weeks post-menstrual age and at least 6 pounds or greater there. It uses a carabine gum, and it adds about 5 calories per scoop. You do have to heat the base liquid to add the gel mix to it for it to mix appropriately. Simply Thick, by contrast, uses a xanthan gum-based thickening agent. It is not recommended for use in children under 12 years of age unless you consult with a healthcare professional. So this would be a conversation with the full medical team about the risks and benefits of using Simply Thick. It doesn't have to be, the liquid doesn't have to be heated for the Simply Thick to work with it. Looking at using gel mix, trying to create different IDSI levels with different types of formulas here. The study from 2021 reports on the impact there. So in this study, we were trying to create formula at the target of nectar or IDSI level 2 consistency, and we were using the gel mix there as the thickening agent. So with progestamil, Enfamil 20, 24, 30, and Similac Advance and Similac Soy, immediately after mixing with gel mix, the formula was at a half nectar or IDSI level 1 consistency, which was below. It wasn't as thick as the desired consistency there. Similac Special Care was at an IDSI level 2 consistency immediately after mixing, and Similac Neosure was at an IDSI level 3 consistency, which was a whole clinical level above what we were trying to create. Trying to create that IDSI level 3 consistency with those same formulas. What you see is that we got greater consistency. So Enfamil 20, Similac Advanced, Soy, Special Care, and Neosure were all at the IDSI level 3 consistency following the directions on the package of gel mix to create an IDSI level 3. The Progestamil, Enfamil 24, and Enfamil 30 were consistently one clinical category below the desired target with the following the directions to mix gel mix to a honey consistency or an IDSI level 3 consistency. Why that happens likely has to do with the fact that you have to heat the formula or the express breast milk that you're using up to 100 to like 120 degrees Fahrenheit to have the gel mix dissolve appropriately within the formula or the expressed human milk. So over time, then what happens is it cools, and as it cools, we do see it increase in thickness to the desired consistency with the cooling there. So yeah, you might have to keep that in mind again with the stand time that you're allowing between when you mix the formula with the thickening agent, gel mix in this case, to then when it's being served for it to be at the right consistency. Brooks and colleagues from the study here in 2024 were using gel mix with expressed human milk, different volumes of formula there at body temperature, and you can see that same effect. So while it started at a thin liquid consistency immediately after mixing with cooling, within 5 minutes it had reached a slightly thick consistency there. The other option that's available to us currently is using baby foods and other types of pureed foods to increase the thickness. So in this study from Brooks and colleagues, again, they were using different pureed foods. So they were investigating the effect of time, temperature, and thickener on expressed human milk. They used oatmeal cereal, commercial thickeners, pureed fruits, vegetables, yogurts, and puddings, and then used the IDSI flow test measured at various temperatures, so both refrigerated, room temperature, and warmed body temperature at different time points from 0 to 20 minutes to document the impact of those things on the resulting thickness. So they were using milk that was donated from a single mother that was collected over 4 consecutive days. The samples were frozen and then thawed and warmed to the desired temperatures. Thickeners included baby foods at room temperature, oatmeal cereal, yogurt, vanilla pudding, gel mix, and Pure Thick. We're going to talk about the pureed foods that they used. Samples were mixed by shaking for approximately 10 seconds, and they were flow tested at 0 minutes, so immediately after mixing, 5 minutes, 10 minutes, and 20 minutes after mixing. So looking first at using yogurt, vanilla pudding, and a very small, like half an ounce of banana mixed with 1 ounce of expressed human milk at various temperatures, you can see that the yogurt remained at a slightly thick consistency across the different testing time points when it was at a refrigerated temperature of 40 degrees Fahrenheit. The vanilla pudding, though, started at a mildly thick consistency, but then quickly thinned, I think, as it warmed over time here. And then it was a thin liquid consistency 5 minutes after mixing. So that's not a great option then for providing a consistent thickener to an infant consuming expressed human milk. The half ounce of banana, they looked at 40 degrees, so refrigerated, 70 degrees room temperature, and then at body temperature. At body temperature, it did not create a thick consistency at all. Even as it cooled over time here, we didn't see it reach a an increased thickness, but both at refrigerated temperatures and at room temperature, using the 1/2 ounce of banana to 1 ounce of expressed human milk consistently created that mildly thick consistency there on the IDSI scale. So then looking at 1 ounce of banana to 1 ounce of expressed human milk, same thing. It created a mildly thick consistency. Looking at peach puree and pear puree, so baby food purees there with 1 ounce of expressed human milk, refrigerated, room temperature, and body temperature. At room temperature and body temperature, we have consistently a slightly thick consistency there. With refrigeration, it started at slightly thick. Then we see it changed, and we had it, they documented it at mildly thick at both 5 and 10 minutes, but it had returned to that slightly thick consistency by 20 minutes there. With the pear consistency, with 1 ounce of expressed human milk, it was mildly thick at that refrigerated temperature, and then we see most consistently a slightly thick consistency at room temperature 70 degrees. At body temperature 98.6, it was slightly thick until it cooled right at the end, and then it was at that mildly thick consistency there. So all of those are potentially good options for thickening. Looking at sweet potatoes, green beans, and squash, those were not great options for thickening. Looking at the temperature impact, all of the measurements with the sweet potato and 1 ounce of carrot to 1 ounce of expressed human milk consistently just gave us a thin liquid consistency. Green beans, though, were thin at refrigerated temperature and then reached a slightly thick consistency after 10 to 20 minutes. But then at room temperature and body temperature, thin liquid consistency. Same for the squash. The impact to create a slightly thick consistency was just with the refrigerated temperature there, and it was consistent at slightly thick, but at room and body temperature, the squash consistency was not a great thickening option there. So using type of thickener, time and temperature, they were able to predict the thickness, or they were able to explain the variation in thickness for 83% of the thickness variation in the sample that they included here. So fruit purees, squash, and yogurt seem to be effective options for thickening human milk, and those can certainly be considered with older infant populations that have dysphagia there. So while we know that thickening is complicated, we do have some options that have been shown in the empirical literature to be viable. That includes the use of a ready-to-feed Enfamil AR formula. Increasing the caloric density of powdered AR formula can also create consistent, thicker liquids. We can use infant cereal. We know the American Academy of Pediatrics recommends using an oatmeal cereal there. There is gel mix as a commercially available thickening option. And then there are those options for food-based products with expressed human milk as well. So thinking about the infant populations and why thickening becomes a little more challenging in that population versus some of our older populations, one thing that we have to keep in mind is the amount of nutrition that the infant has to consume to meet their growth expectations. So from birth to 12 months, the infant is expected to increase 50% in length. From birth to 12 months, they're expected to increase their weight by 200% as compared to their birth weight. And growth is a relative indicator of the nutritional intake and feeding skill competency that the infant has. So it's really important that they're consuming the right amount of expressed human milk or formula during this time in order to meet their growth expectations. So we know that to do that, the infant has to feed either from the breast or from the bottle if they're going to eat by mouth. So to accomplish nipple feeding, the infant has to regulate the flow of fluid from a region of high pressure into that region of lower pressure. Fluid is propelled to the area of lower pressure. So essentially, milk or formula is housed in the breast or the bottle. The mouth is grasped around the breast or the bottle, and the nipple provides then, or around the nipple, which then provides a closed system with equal pressure in each chamber between the mouth and the bottle when the infant has a good latch around the nipple. So then when there are changes to the oral cavity volume with movement of the tongue or movement of the jaw, then we see the pressure within the oral cavity is lowered as the space in the oral cavity increases with movement of the tongue or jaw. And that is what allows then for milk or formula to be sucked into the oral cavity. And that's accomplished with both expression and suction. So positive pressure and negative pressure. And we can see that illustrated here. So you can see the infant's tongue providing positive pressure on that nipple, narrowing the neck of the nipple there, and then movement of the jaw and tongue that creates a lower pressure within the oral cavity, which then draws the fluid into the infant's mouth. So we have to have both components for the infant to competently feed. They have to have both the expression and compression components of nipple feeding for them to have success. So we know that nipple size and other characteristics can impact the flow rate of expressed human milk and formula from the bottle, and that bottle nipples are largely unregulated products. There are no regulations about flow rates or how they're marketed or named, and you know that from having gone to the store. If you've seen the wall of nipples or looked on Amazon or Target websites, there are all kinds of claims about what bottles and various nipples can do that are largely unregulated by the federal government or any other agency there. So we know then that why thickening works is that it slows the flow rate from the bottle, and that it also increases the cohesiveness of the bolus there. So thickening slows the flow rate and it increases the flow variability of nipples from the same brand. So when we alter how thick something is, it's going to impact how it flows from the artificial nipple that it's being served from. And there is some data that has been provided by Dr. Britt Pados and her group that has looked at the various flow rates and challenges of using thickened liquids across a number of different products, including the Dr. Brown products here. So the flow rates of the Dr. Brown's Medical Ultra Preemie Nipple, Preemie Flow Nipple, Newborn, and levels 1 through 4 were tested with 3 different thicknesses of formula in Dr. Pados's lab. She looked at IDSI level 0, level 1, and level 2. She measured the mean flow rate and the coefficient of variation of the flow rate for each nipple type that we've already talked about across the 3 different thickness levels that we talked about, and she looked at each combination of those things. She was using thickened Similac Advanced, so just a standard 20 calorie an ounce formula. It was ready to feed, so just open the package and ready to go. And it was mixed with gel mix that we've talked about previously, and so we know that it has to be heated and then mixed with gel mix for it to create the desired consistencies there. To do her flow rate measurements, she tests the various bottle and nipples with a standard breast pump, which means that she's only looking at expression. So only the suction component, not the compression component that we see in infants. Infants use both. They use the compression against the nipple and then the changes in the oral cavity volume to express or to draw in the fluid from the bottle or from a nipple. We know that infants feed with variable sucking rates and pressures within a single feeding, that healthy term infants that don't have dysphagia and are not experiencing feeding challenges, that they can consume they can vary their sucking rates to accommodate for changes in flow rates from increasing the thickness there. And Dr. Pados describes her flow testing in this methodology, and she gives the caution that it's not intended to replicate infant feeding because she can't replicate the compression component there, and she can't replicate the changes in sucking physiology that the infant might do in response to different flow flow rates or different thicknesses there. And so within her reports, she says that the reported flow rates are not intended to be reflective of flow rates that an infant might achieve during oral feeding. So we have to keep that in mind. What she reports is that the IDSI level 0 or thin liquid flows fastest from the Dr. Brown Company level 4 nipple and slowest from the ultra preemie nipple, and that's been documented across other studies as well, and that there's a statistically significant difference in flow rate between the 7 different nipples that she tested. Using the slightly thick consistency, she reports no statistically significant difference in flow rate between Dr. Brown's medical ultra preemie and the Dr. Brown's medical preemie flow, and no statistically significant difference in flow rate between Dr. Brown's medical newborn nipple and Dr. Brown's medical level 1. All other nipple comparisons showed significantly different flow rates, slowest to fastest in order of presentation. Looking at level 2, we see similar results. There were no statistically significant differences in flow rates between Dr. Brown's medical preemie flow nipple, Dr. Brown's medical newborn nipple, and Dr. Brown's medical level 1 nipple. She was not able to achieve flow with the Dr. Brown's medical ultra preemie when using this level 2 mildly thick consistency. No statistically significant difference in flow rate between Dr. Brown level 2 and Dr. Brown level 3. And then again, all other nipple comparisons showed significant flow differences in flow rates, slowest to fastest, again in order of presentation there. So work to establish flow rates of bottle nipples was completed under laboratory conditions. So that's different than actual feeding conditions because the infant feeds differently than what we can replicate with a single breast pump. The kind of work that Dr. Pados has undertaken can't replicate in vivo flow rate conditions that an infant may achieve when feeding. They may increase their sucking pressures or decrease their sucking rate in accordance to the flow that they're receiving. And so information and data about flow rates, particularly with thickened feeds, has to be used as a guide for decisions about nipple selection, but has to be tested empirically, tested clinically in your facilities to understand which one is the best nipple for the prescribed thickness that the infant is using to combat symptoms from GERD or from oral pharyngeal dysphagia. Empirical data about nipple flow rates then is not a substitute for thorough and accurate clinical and instrumental assessment. So if you're having challenges with clumping as an example, or inconsistent thickening results, then you can use a finer grain cereal or you can pulverize the grain. You can also try mixing with an immersion blender or with a whisk. If you see increasing thickness over time, you can consider changing your thickening agent, or you can consider the time between when you're mixing and when you're providing the feeding and seeing if you can adjust that. And then also consider the temperature of the feeding, knowing that when it's warmer, it tends to be thinner, and then as it cools, it gets thicker. If you see that the nipple is clogging, then you want to confirm the thickness with either a line spread test or the IDSI syringe test. Consider using a different nipple if it's confirmed safe with objective instrumental testing like video fluoroscopy or FEES. And of course, we're not going to advise families to cut or manually enlarge the nipple hole because we have products that don't require us to do that and that won't damage the integrity of the bottle nipple system by us manually cutting it. If we see increased or decreased intake from the infant, we need to consider the extraction time and the total feeding time. Did we see changes after we started the thickener? We want to confirm that the thickness is the right, the prescribed level. You can do that with a line spread test or an IDSI syringe test. We might consider a different nipple if it's confirmed safe, and then we can consider other thickening options if none of those other interventions work. If you see a change in stooling pattern, then you might consider the thickening agent and changing it if necessary. And then you might try rotating between different thickening agents if difficulties in stooling persist. So these are some considerations when we're thinking about thickeners. How old is the infant? What are they drinking? Can they tolerate extra calories? Are there any contraindications to using a thicker liquid? If they're less than 1 year old, if they're more than 42 weeks and drinking expressed human milk, you can use gel mix, same as if they're doing formula and they don't need additional calories. If they're less than a year but drinking formula and they can tolerate additional calories within their diet, then using something like cereal, purees, or yogurts may be appropriate. I hope this information has been helpful. Thank you to Dr. Brown for the opportunity to be with you all here today. And I look forward to answering any questions that you may have.
Any questions not answered today? I mean, actually, all questions will also be on the website when the webinar is posted. We will get to all these. And I'm already thinking we need a part 2. This topic is so many questions. So let's try to tackle some of them. Okay, Memorie?
Yeah.
All right. I'm going to start at the beginning because I think it goes along with your PowerPoint and that may help, answer some of those. So someone wanted to know if you could talk a little bit more about what you mean and just elaborate on that hand mixed thickened formula.
Absolutely. So hand thickening just refers to you taking an external thickening agent and adding it to your formula or the expressed human milk that you're using. So that's what hand thickening means. It's in contrast to using like an Enfamil AR that's pre-thickened.
Yes. So thank you. Thanks for, and remember everyone, it's like some people are just beginning to learn about thickening. Some have been doing this for years. So some of the terminology is different for all of us. All right. Did the study. Now, this is towards the beginning of the webinar, so now I'm not sure which one it is, but did the study measure percentages per swallow, or how did they determine the percentages of penetration? I'm not sure if that person is still on that. If Memorie knows it, or do you know what they're talking about?
Yeah,
Okay.
I do. So it was in the Miller study. And so what they did was they collected the total number of swallows that they observed. They counted the number of swallows that had penetration events, and they divided that by the total number of swallows observed. That gave them the percentage of swallows that had penetration there.
Okay. Thank you.
Uh-huh.
All right. I know there are a lot of questions about breast milk.
Mm-hmm.
And first, before I go through, I mean, they're all over the place. So
Yeah.
I'm going to have you elaborate on it more because there's also, as you saw, a lot of questions about can we thicken breast milk? What to thicken it with? All the questions about breast milk. Do you want to elaborate on that? And then I'll see if
I saw several questions about using expressed human milk and how all the options to thicken with that. Several people alluded to the fact that there is amylase in the breast milk that will break down some of the carbohydrates that are in the different thickening agents. Yes, I've heard that as well. What I would say about breast milk is that it's dynamic. Every day it is different. Every mother that you may have collected a breast milk sample from is going to have a different caloric density and a different makeup of the macro and micronutrients that are part of that breast milk. So it's very difficult to give like a blatant, you can do this one thing for all the different breast milks that you may encounter. The studies that we looked at today used one mother who pumped and gave them a sample of her breast milk. I think that was collected over 4 days. So they had as much as breast milk can be homogeneous, they had a homogeneous sample of that. So I would say you need to test breast milk specific to the parent that is giving it with the different thickening options that may be available. The one that is probably the most universal and will provide the least amount of variability is going to be using gel mix. So that is the easiest answer there. The challenges with gel mix are primarily around expense and availability. It can be difficult to get. It's now on Amazon. I've purchased it from Amazon, so I know it's available there, but even with that, then the cost is a factor, and getting it with insurance can be really challenging. So using your case manager, if you're in a hospital setting, with letter of medical necessity, especially if the parents are dedicated, the only thing they want to do is to provide breast milk. They don't want to use other options there. There were questions also around using the pureed foods as a thickening option and when would that be appropriate? It would be appropriate when the infant considering if their preterm is at a corrected age when they would be starting pureed foods in their diet. So that, of course, like with any thickening agent recommendation, is going to be a conversation between you, the dietitian, and the physician about which options are most appropriate for the infant. But the general rule of thumb there is that if the infant is at the postmenstrual age or the corrected gestational age when they would be starting pureed food, so usually that's somewhere between 4 and 6 months of age, and they've added that to their diet, then that might be an option then to use as a thickening agent. And I think it was the Brooks group used that with human milk and showed some efficacy there for thickening.
Great. Thank you. Very thorough. And I love also that you said individualize mother's breast milk, as it does.
Yeah.
And that is so important.
Yeah.
We don't have any rules about, all of breast milk. So I love that. Thank you. I think people struggle with this a lot. How do you balance offering opportunities for thin oral trials to improve or support swallow function with an infant or child who's also on thickened feeds for GERD?
Right. So I think we need to think about making sure that the GERD is managed first before we start thinning things down. And you can do some clinical trials there. If the concern with or the reason for using thickened liquids is primarily for GERD, then we're not concerned about the child aspirating necessarily from swallowing a thin liquid consistency, then you may be able to systematically trial different volumes. So increasing volumes of thin, monitoring for any changes to lung health, monitoring for that impact on reflux events, and document that way to guide your recommendations for doing that. That would be a starting place, I think, because it is important that the infant have opportunities to try feeding by mouth with standard, breast milk or formula consistencies. But if what we're doing is causing them to have pain or other associated events that are unpleasant during feeding, we don't want to do more harm than good. So I think talking with the medical team, presenting a plan to kind of systematically increase what's being offered by mouth thin liquid, if you know that to be safe and appropriate for the infant that you're working with, and then monitoring for any changes in reflux events.
Great. I love it. Safe and individualized and positive feeding experience for all. Can you address the question about thickening of infants with an NG?
Yeah, so different formulas and different consistencies, of course, can block NG. We've had success in our hospital setting with using an Enfamil AR through the NG tube. So that is slightly thick, so IDSI level 1 consistency. So that we've used that clinically and had success there. The other option is using something like a gel mix where you're going to have a smooth consistency that comes through there. If you're using cereal or if you're using a granular kind of thickening agent that's more starch based, then it does get thicker over time. And so that can be difficult, especially if you're hanging to gravity for the NG feedings. Sometimes using a pump will make that more successful there. But if you're using something that's more granular, that tends to get thicker over time, you do have an option of, this was in the questions too, about pulverizing cereals to use that. You can, the caveat and the caution is that you are significantly increasing the caloric values when you do that. So in all the studies that we talked about, the amount of rice cereal was just what was taken out of the box, it wasn't pulverized down. So we're talking about a teaspoon or a tablespoon of cereal just as it comes out of the package, versus when you use a food processor or a blender or something to pulverize it down, it does make a finer grain, but you're also using 2 to 3 times as much of the cereal when you do it that way. So your caloric value is going to go way up, and your team just needs to be aware of that.
Yeah, thank you for clarifying. There were a lot of questions about that. And speaking of, you brought up Enfamil AR, any age limits for that? There were some questions about that as well.
Yeah, so Enfamil AR, if the infant that you're working with is on a standard cow's milk formula, then Enfamil AR is an option for that infant. So if they're on a hypoallergenic or a semi hypoallergenic formula, then Enfamil AR wouldn't be an option. But if they're on a standard cow's milk based formula, then that's what Enfamil AR is. So it can be considered an option there. I saw the question was about specifically in the NICU. So it would be a conversation with the neonatologist and the dietitian about that. But typically your rule of thumb is if they can tolerate standard cow's milk formula, then Enfamil AR can be an option for those infants.
Okay. And then expanding on that, AR questions about does it continue to thicken? Can you get it moderately thick? Those questions about how it thickens and times.
Yeah, so the study that we have that Dr. McGrattan led, we looked at Enfamil AR ready to feed. It's stable. It was stable across that 30-minute testing period in the ready to feed package. When you mix it from a tin, so you add water to the formula granules and mix it that way, it does tend to get a little bit thicker over time. So it starts out as a thin liquid consistency, and then eventually it gets to that slightly thick consistency. I think in the paper it said after 5 minutes of stand time, it reached that consistency, and then it was stable across the remaining time points up to 30 minutes. You can get it thicker. You can add a thickening agent to it to get it up to a thicker consistency, but you would have to clinically trial it out and see how much of the thickening agent you need to add to create the consistency that you're going for. But at a slightly thick consistency, that often is enough thickness to eliminate the penetration or aspiration events that are worrisome under video fluoroscopy. And there was a question in there too about barium and how to create a slightly thick consistency there. So at my facility and at other facilities that I'm aware of, we use the Veribar product line, which has been tested and equivalence has been established with the IDSI levels. So we use the Veribar thin liquid consistency and the Veribar nectar consistency in a 1-to-1 ratio. So for making an ounce, we'll use 15 mLs of the thin liquid barium and 15 mLs of the barium. The nectar thick barium consistency, shake those together to create that slightly thick consistency to test under fluoro. And I have a reference for that I can share with you that you can use.
All right. What about do you have any other thickening for allergies? I guess one would be baby food, right?
If they're old enough to use
Yes.
that.
Yeah.
You can, so there are other thickening agents on the market other than the ones that we talked about today, but the challenge is that they're not marketed. Their labels don't say this is appropriate for infant use. So and that doesn't mean though that you can't use it. It's just a conversation with your medical team, because then you would be using something off label. The product itself doesn't say it's appropriate for infants. Physicians make these decisions all the time based on their risk benefit analysis. Sometimes they'll recommend like reflux medications in infant populations that haven't necessarily been tested or are recommended for infant populations. So that if you need a thickening agent for allergy reasons that none of the current thickening options meet your need, then you can talk to your team about what the other options are, the risks and benefits, and see if that's a recommendation that the team would want to make.
Great recommendation. Thank you. There was a question. Well, I think you kind of addressed it, but just to emphasize about, would you thicken only after instrumental assessment?
Yeah, so I know that that's controversial. For me, yes, I wouldn't want to do empirical thickening trials at the bedside because we don't know that it works or that it doesn't unless we see it with fees or video fluoroscopy. So the literature that I'm aware of and the clinical data that I'm aware of, it works in eliminating penetration and aspiration events in about 50% of the infants that we trial it with. So that means in 50% it doesn't work. And then I've introduced a thicker consistency that the child is aspirating that then is more difficult to cough out and to clear from their pulmonary system, which could then increase the adverse outcomes that can come from thickening or that can come from aspiration. So in my clinical practice and others, that I don't do empirical thickening trials. Yeah.
Okay. Do you see any other? I'm trying to make sure we address everything. Do you see any other ones, Memory here? Um,
There was a question about Simply Thick and what it had been reformulated in
oh, yes, 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 yes.
2007.
Thank you.
Has there been any research since then? And I would just say no, but there wasn't any research before either, right? Like there was an unfortunate
Yeah.
event, that happened clinically where some infants that were receiving large amounts of feedings on that were mixed with Simply Thick that were going through the tube and by mouth developed that late stage NEC. The investigation into that showed that there was some bacteria on the manufacturing line for all of the Simply Thick that had been given to those infants that developed that late stage NEC. So because of that, and out of an abundance of caution, it was just pulled and said, we don't recommend that you use this product in infants. At all, right? But prior to that, I know at the facility where I worked, we did recommend it and used it frequently, especially for infants that were receiving breast milk as their nutrition source. So I don't know of any research that's been done because I don't think there was research done initially around, using it in infant populations. And certainly with the events that transpired, it's not considered like a globally safe option. But again, it would be a conversation with the medical team about, is this an option for the infant that we're working with, given all of their history and factors?
So much of this is individualized, right?
Absolutely. Yeah.
I did see a question that was really interesting also. AR maybe level one-ish. So we know that that's what they
Mhm.
say, right?
Yep.
But it's reported, we know it thickens further in the stomach
Mhm.
when exposed to gastric acid. So do you have any idea about how they thicken in the stomach when an infant is on blockers or PPIs?
Yeah, so it would impact there. And my understanding was that it was the other AR product, like the Similac AR product.
Yep.
Spit up, yeah. So that's what I understood was the one that was designed to mix in the stomach because it is thin. Like out of the package, it's thin. It didn't get thicker over time. So that product, my understanding from the manufacturer was that it was designed to thicken in the stomach to prevent reflux episodes. So I'm don't have that in my head for the Enfamil AR because it was thicker out of the package there. But if the infant's on PPIs or any other type of reflux medication that impacts the pH of the stomach, then absolutely it's going to impact how that product that's designed to thicken in the stomach would work. So the team would need to monitor what was
Yeah.
happening with that one.
Okay. And probably great advice for therapists or nurses would be to consult with the neo or the physician and the dietitian as
Yeah,
well.
and the manufacturer of the product, ask them.
Absolutely. Okay. There are a lot of questions also, let's see, about recipes.
Yeah.
Can
So
we comment
in
on
the
recipes?
the papers themselves, they will give the recipes. I think on some of the slides it talked about the different recipes that were used, whether it was 1 tablespoon or 1 teaspoon. So there are 2 or 3 slides right in the middle of the presentation that give you all of the recipes that were used in those studies.
Yeah, and then as a reminder, I know everyone has asked about the handouts. We will providing you the handout. So we will get those to you as well. So we are now at 1:20. So again, I just want to thank everyone for being here. Memory, thank you. You are a wealth of information. This topic is so complicated and I don't think we're done yet. So we'll see if we can get Memory back here, everybody.